It's a very, very exciting morning. We have online, let's start from the top left on my screen here, Sergio Rudeloso. Good morning, Sergio.
Hello.
How are you?
Fine, and you?
Oh, very well, very well. Long time no see.
Yeah, look forward to start this very interesting webinar here.
Yes. And we have Kirsten Dort, who is our e-training specialist. Good morning, Kirsten.
Thank you. Thank you for the invitation.
Oh, a pleasure to see you. And we have, of course, last but not by no means least, Lorenzo Danova, all the way from Milan in Italy. Good morning, Lorenzo.
Morning, guys. Chokin. Happy to be here with you as always.
Good to see you, my friend. Good to see you. And we are getting a few more people online. We'll just maybe wait another couple of minutes to see if anybody else will join us before we begin the presentations this morning. Very exciting. Yesterday we did the session. So normally when we're doing these series of webinars, we do one in the morning and then one in the afternoon. But this time we decided to do one in the afternoon and then one in the morning. Why? Because yesterday we had a very special guest all the way from Maceió in Brazil, Professor Bruno Freitas, presenting about atherothrombectomy in native vessels and in stents and so on. Very, very interesting presentation. The good news is we recorded it for you, so we can see it. We can see the recording of that. It's obviously a little bit early in the morning for our good friend Professor Freitas to be up. I think in Brazil at the moment, Sergio, it's maybe 2 a.m.
Yeah, exactly.
Something like
More
that.
Or less.
So we let him sleep a little bit today. That's why we did it the other way around. So without further ado, let's begin. And I'd like to introduce the first speaker. That'll be me, Kenneth Brown. Nice to see you all. And we're going to talk about the functions of Rotarex, which we can discuss in the atherectomy setting. So we'll start with a little bit of an overview on atherectomy. Now, most of you are very familiar with this concept of atheroma removal from vessels. There are various devices, but we can dive deep into the market and we can see the types of different devices. In the US, the atherectomy market is very well established, and they have 4 distinct categories of atherectomy device. They have directional atherectomy devices, such as the Hawk series of catheters. Now, these, you have to have a good orientation in the vessel for them to work properly, okay? And they are used for treating stenosis, okay, not occlusions. We have orbital atherectomy devices. Now, some of you might be a little bit familiar with this one here. It's called the CSI Diamondback 360 Peripheral Atherectomy Catheter. But not everyone will be familiar with that one. It's not widely available outside US at the moment. It is coming to the market though. And how this works is an oscillating wire, which has a crown. They call it a crown. This is a diamond dusted abrasive sander, which as it's spinning around in the vessel, it's making contact with the calcium and breaking that down into what they say is extremely small particles that then get flushed out through the system. We have laser atherectomy devices, devices such as the Xymer laser, which this week I believe is owned by Philips, not sure. But this is using a cold laser to ablate that calcium in the vessel. And then we have rotational atherectomy devices such as the Jetstream. The Jetstream, I think you're all familiar with. Boston Scientific device has 2 modes of action: blades in, that's for removing occlusive material, and blades out, that's for cutting away atheroma. Also in this rotational atherectomy, we have the Rotarex. Rotarex is classed as a rotational atherectomy plus thrombus removal device. Math. We're talking about math. Let's do the math today. So we are all very familiar with the Rotarex concept, an outer rotating head, which is spinning around 1,000 times a second, depending on the size of the catheter. That head has these distal facets which break apart the material, and everything is aspirated into the catheter. We have the 3 main sizes here, 6, 8, and 10, and we can treat vessels from 3 millimeters all the way up to 12 millimeters. So we can pretty much treat everything from popliteal to iliac. And we're going to talk a lot about iliac today as well. Indications, as you know, for the Rotarex are very wide. They are very wide. We are treating stents, stent grafts, bypass grafts, native vessels, atherothrombotic occlusions, thromboembolic occlusions, etc. I think you all know this. This is just revision. I want to come on to the Rotarex as an atherectomy device. This is really important, everyone, because this is our focus. We can really make good business selling Rotarex in the atherectomy space. How do we discuss it? You know, we've got a bit of experience now in the US market of targeting physicians who are treating atheroma with such devices. So what do we know about the Rotarex? Well, firstly, we have these half-moon facets at the distal tip, and they are like an electric drill, like you're going to make a hole into your wall. You have a smooth surface, and as the drill is turning, we are breaking apart that material and really bringing it out of the wall, not pushing it in. That's why you always need to have a vacuum cleaner handy when you are doing some DIY. But the great thing about the Rotarex is it also acts a little bit like a vacuum cleaner, because we generate that suction by the rotation of the Archimedes screw. And we are actively aspirating right from the tip of our catheter, because the helix goes all the way through. So we are moving the material actively from the vessel right from the tip through those large cutting windows. Remember the cutting windows, as the head rotates, it's a little bit like a pair of scissors, okay? The outer head is turning, the inner head is static, and as the head turns, any particles which are aspirated into that window are cut up as they pass through. Okay, remember again, Rotarex is an over-the-wire device, and that's also important because not all of our competition are over the wire. And I've just talked about all of this with these nice colors, but you know, the facets, the outer head, the inner part of the head, which is doing all the cutting, and then the transportation out of the vessel. Remember, as that head is turning, we're generating a vortex. Okay, here's just an overview again of the system here, the catheters, and also on the right side of the screen, just a description of each part. Now, these slides will be made available to you shortly. So, again, a visual for that mechanism of action of the Rotarex. I think this is always a really good thing to show. We have that the facets at the tip of the catheter really drilling in to that chronic calcified material, and is able to break that apart. And then we have the action of our vortex. And that vortex is eroding, further eroding away all of that atheroma in the vessel. By hurling around the particles, we're creating like a rock tumbler effect. And that breaks everything apart, and it's sanding away that calcium, along with also the tip of the catheter, as we'll see in a video demonstration during this presentation. And we can see this vortex effect. We can see this vortex effect. Sorry, everyone, these videos are strange. We can see the vortex effect in this ultrasound video. At the bottom of the screen, those particles being hurled around the Rotarex head while it's running. And that's what's really making a difference with our catheter, why we are able to clear a much larger lumen than the catheter diameter. And last but not least, we have the fragmentation. Fragmentation occurring in the head and in the helix. As that helix rotates, it's breaking apart that material while it's transporting it out of the patient. Okay, so I always like to show something that's easy to remember, and I don't think many people will forget seeing a pool ball being destroyed by an industrial shredder. Then we're going to move on to the Archimedes screw principle. The Archimedes screw principle demonstrated in this video here. As we rotate, we generate an active transportation, in this case of the water, from the pool below up to the top, and then it falls back down into the pool again. But in our catheter, no, it doesn't. It falls into the collecting bag. So we transport it out of the patient using the Archimedes screw principle. Now I just want to show you this video, which is really, really good. Very poorly made. I apologize for that. Sergio was going to buy me a beer at the Christmas party on the day that I filmed this video, which is why I did it so fast and I didn't get rid of all these air bubbles. Sergio, thank you. I enjoyed my alcohol-free beer courtesy of you. And what we see here, this is solid calcium, ladies and gentlemen. This is solid calcium that the Rotarex is, you see how it's eroding away. We have to use a little bit of a special technique when we are working in calcium. We are doing a pecking forwards and backwards rather than a head length into the occlusion and back into the blood flow like we would normally recommend. And it takes a little bit longer in calcium. So this model is completely unrealistic. We would never see this in a, or virtually never see this in a vessel where we have a solid chunk of calcium. It's much faster when we have flow around the head and we have a stenosis caused by the calcification, not a CTO with calcium. Okay, but you can see here that we are quite effective at getting through that. That took about 4 minutes to get through this block of calcium and to really make a channel, which would then, of course, go on for further treatment, stenting, maybe cutting balloon plus stent, definitely drug-coated balloon. We would do something else in this scenario. Indications for Rotarex, again, we touched on these and I think you all know them. We have those native vessels, stents and stent grafts, and that's the real power indication for Rotarex, especially where we have a lot of neointimal hyperplasia. Bypass grafts and dialysis access. And we can treat any age of occlusion provided we can pass the guide wire. And we can also treat atherothrombotic, thromboembolic, and thrombotic occlusions with the device. A summary of the key information here. Remember, we have two lengths for the 6 and 8 French Rotarex, depending whether we're going contralateral or ipsilateral access, crossover, or same side. We have different lengths of guide wires, of course. All of our guide wires are exchange length. So the longer the catheter, the longer the guide wire needs to be. And the aspiration capacity approximately doubles for each increase in size of our catheter. So 6 French is 45 milliliters per minute, 8 French is 75, and 10 French is 130. And we have a range of vessel diameters that we can treat from 3 to 12 millimeters. Now, again, this is all information that you know, but remember this dual indication is important. Atheroma and thrombus removal with the device. We are removing that atheroma. If any of you have ever done a case in calcium, you can hear the calcium passing through the catheter. It's like a tinging sound as you're passing through that calcium. And a lot of lesions have a little degree of calcification in them. Okay, we're not making contact with the vessel wall. We're using the inherent properties of a fastly rotating catheter to have the effect on the atheroma. So we're not cutting it out, okay, which has a disadvantage that we don't always clear all of the atheroma out the vessel, but it has the big advantage that we're not causing vessel wall damage, because the devices that cut that atheroma out are not, they are non-specific. So you can cut out vessel wall as well if you're not careful. Remember, we don't cause hemolysis, not like the jet stream. Jet stream is bad for the hemolysis. We're increasing the luminal gain. Now, this is a concept which is coming from America. It's coming to a cath lab near you soon. People are talking about luminal gain. We are getting a luminal gain much bigger than our catheter because of the inherent properties, okay? And measurements are coming on that. And we have a wide range of clinical and cost benefits with the device. Too much to talk about in this presentation today, but I think you know all of these, all of them. So there we are. That's the brief overview of Rotarex as a mechanical atherectomy device. I can talk more on that, but I think it's much better that we jump now to our good friend, Professor Bruno Freitas from Maceió in Brazil. Remember, this is recorded from yesterday. You'll know it because Lorenzo's hair was a little bit more yesterday. And Sergio's smile was a little bit broader. No, I'm kidding. It's always broad. So here we go. Sergio, over to you.
Start. Okay, I mean, I just start the video. So I remind our audience to feel free to make the question to our panel directly into the chat. So communicate with us whatever you want to know or you want to comment. Now we start this presentation from Professor Freitas.
So, Professor Freitas, when you are ready, I will shut up and you can go on.
Thank you very much, Ken. I mean, thanks for, actually, I would like to start by publicly asking you for those videos. I mean, those were great. Even the ones you said they were bad quality, I mean, they would be of great use. I mean, I really love them.
Only if you don't tell anyone.
No, I won't. I won't. And I mean, I also don't believe that even in Christmas, you were able to get something paid from Sergio. But anyway, it was Christmas time, so maybe his heart was a little bit more soft.
Probably should have.
You guys see the screen? So please, we are in a very intimate, close group. So please feel free to state your questions. I would like really to stimulate, to handle them to Sergio, to the guys, so that we can have a good discussion after that. But let me start by saying that in the real world, things many times do not work as we have in the books in the theoretical world. So in theoretical world, we do have acute, subacute, and chronic lesions depending on the time. Up to 14 days, acute, 14 to 3 months. 14 days to 3 months, it's a subacute lesion. And after 3 months, we enter into the so-called chronic scenario, chronic lesions. If this is a total occlusion with more than 3 months, we can also rotulate them as chronic total occlusions. But in real world, it's not so easy to differentiate them. So if we look to this picture on the left side of the screen, we see a material inside the vessel which looks like pretty much with an acute setting, but you have a lot of collaterals. You have a stent previously implanted over there. So this is probably a chronic patient that had an acute occlusion. How will you classify it? Is it acute? Is it chronic? Is it subacute? Can you, by the image, tell how long the history of the patient is? Probably not. If we look to the two images on the right side, you also see a lot of collaterals. You see a very long occlusion beginning in the offspring of the SFA up to the adductor's canal. So you have no SFA almost, and then you end up with the refilling of a P1 popliteal segment. This is highly probable to be prone to be a chronic patient, but we will look after that further again. But the main point is, in many situations, we deal with patients that with an angiogram like this. Decompensated ischemia, very low flow, patient with a risk of losing his member, and then you look up, it's a very, very long occlusion, and you have a refilling through collaterals here in the P2 segment, retromalleolar, very long, and you say, okay, this is going to take me 3 hours to overcome. I'll have to do a retrograde approach. I'll have to do a re-entry device. I'll have to work, blah, 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 do stents, whatever. This will take me time. And then you start with a guide wire. It's a patient with a 4, 5, 6 months history, 3 months history, and by that, obviously, a chronic patient. But then your guide wire with a support catheter just goes down. We are here with a soft angle terumo. And after that, you see yourself going all the way down, and then suddenly, without so much fight, being able to come back to the true lumen. And your assistant, your residents, your colleagues think you have the better right hand of the world. And it's obviously not. You are dealing with a soft core material. You're dealing with a fragmentable material. And therefore, no matter how old, and how long this disease is, you remained probably intraluminally, and therefore, this is a lesion that can be fragmented, that can be aspirated, and probably you do have one or more sites of culprit lesions that provoked a significant reduce in the flow, and then the rest was a positional soft thrombus due to this initial occlusion. As we can see here, we have another patient also with a chronic aspect, as you guys can see. But then after one passage, you can see a very good lumen. After 3 passages, things are more segment, and then you go for DB in the whole segment. And even though it's a long lesion, you were able to open everything, and without stenting. So thrombolysis would not probably be available here. No use, since it's a chronic patient, too old. Aspiration, just unfeasible. You cannot use it. So what will you use? Either you will, and those soft core patients, those are the patients, the nightmare patients, because if you try to balloon such a long occlusive soft core lesion, you will probably manipulate soft material, cause that massive embolization that will be impossible to pick up everything. And this was a 3-vessel runoff patient. So this will be a disaster. We will end up bringing the patient back to a situation pretty much worse than it was before our intervention, probably. So we have a, I would say, very interesting experience with this kind of device now, almost since 10 years. And we managed, actually, I would like to tell publicly, Paul, that we finished the chronic. So this data we finished for publication this week. Not this one, but the second one, which I will present. So we started publishing data regarding our acute and subacute subset of patients. We published something also about acute mesenteric ischemia patients treated with Rotarex. We are now with 2 papers ready also with Aspirex and Rotarex in chronic patients. But it's more than 1,000 patients in the cohort of native patients. If we think about embolic sites, we need to remember that most of them, as we are dealing with our doctors, we need to be aware that in more than 60 to 70% of the patients, if you're dealing with embolic patients, we are talking about femoral bifurcations or popliteal artery. This is the most frequent. So everybody talks about aspiration. We know it's time dependent and also size dependent. So in this short, very short, straight segment of occlusion emboli, thrombolysis doesn't work. Aspiration will work quite well. But what about in this long lesions? You end up probably 75 years old before aspirating everything, and it will not be good at all. And especially if there's embolic material. If you don't have any better tool, you end up cutting this patient in order to take everything out. So in terms of thrombolysis, depends also on the age, and this is one of the great advantages of Rotarex, as we'll see in chronic patient. Age is definitely not an issue. So and obviously in cardiac thrombus, it makes no sense because you have harder materials. So if you look here, this is after 14 hours of thrombolysis. Can you imagine what it is to keep a patient 14 hours with a catheter inside in the ICU doing our assays of fibrinogen every hour to watch out whether it's okay or not? So obviously, even though people talk about low dose, we have a lot of severe contraindications, but we also have severe complications due to the use of the so-called low-dose thrombolysis. I'm sorry for the images, but they are all from patients. And if we look to the published data, so it's a very important publication, the TOPAZ trial, we see that there is, yes, a highly significant difference in terms of bleeding complications. So this patient, we had an intermediate result, we know how many hours, and then after 20 hours of local lysis, continuous lysis, and some good adjustments, you got a good result, but unfortunately not without some complications. We are happy that those were local. So thrombectomy, we know that it works okay. Let me just show you 3 scenarios. I'm pretty sure that Lorenzo will also talk about the ILEC scenario. It's a little bit more challenging, but here we have a patient with a 4 days sudden onset of symptoms. Here we have a P2 and below the knee, also acute root of 4 severe ischemic patient. Here we have long, so-called subacute, but they look pretty much like chronic occlusion from the aorta to the distal femoral, superficial femoral, and another so-called coat, subacute. But if you look at the number of the collaterals, you know it's subacute because the patient tells you it's a 6-week history. But he is a chronic patient. This isn't a subacute on chronic patient. So as we can see here in this first publication, even though it's a publication about acute native arteries, almost 60% of those were more than 15 days. So the material is organizing. And we did mostly through crossover, the high majority FEMPOP. We're not talking about highly calcified lesions. Most of them were de novo lesions. And as you can see here, just to show you the result, I mean, we have very, very good results, very interesting results with single session, fast section, safe sections in different scenarios of acute and subacute situations. Very successful procedure. Mostly we're talking about the atherothrombectomy procedure here. It's mostly thrombectomy because we're talking about acute settings. We are talking about unmasking a culprit lesion and then treating definitely the culprit lesion more adequately with less metal. If we think about the metal we left behind, the vast majority of those was spot stenting, was not full-length metal behind, and we know this makes difference. No severe complications regarding to the device. The perforation were guide wire perforation, very stable result after 1 year. Here we have 6 weeks left pelvic occlusion, crossover, Rotarex S, 8 French, 2 passages, then a 3rd passage, kissing balloon, final result. And we know that after Rotarex S, I mean, as we talk about chronic patients, the chronic CTOs, I would like to tell you that CTO is much more common in those critical limb ischemia patients. So many of those patients which we treat and we talk, they are acute. They have an acute discompensation, but they are in their history chronic patients. Among all of those patients that I showed you guys, only 2 patients were purely acute. The rest of them were acute on chronic or subacute on chronic. So we need to keep this in mind. Even though the aspect of the patient may look an acute decompensation, I mean, they can be chronic patients, but this for the Rotarex makes no difference at all. As we look to the histological aspect, we'll see that after a certain time there is organization of the thrombus, and we have inside that previously occluded material, we do have a lot of layers of elastin. We do have organized thrombus, but also in chronic patients with atherosclerosis, we do have the formation of the ulcer within the plaque. Then you have thrombotic material, a positional thrombotic material. You do have fibrotic tissue, and as this lesion chronifies, you do have a lot of microchannels that also open the possibility of soft material. So as we can see here, we do have a lot of calcium in this scenario. We have here on the right side, the most to the right side here, we have the plaque being ulcerated. We have an arrow here, a red arrow. I don't know if you guys can see. So now the plaque is ulcerating. You have soft material, ulcer, you have thrombus, you have then the occlusion, and then after that, a lot of fibrotic material, which are soft material that can be fragmented and can be taken out from the vessel. And as we think about calcium, if we look to the literature, less than 10% of all lesions have really severe intimal calcium. So calcium is not an issue in the vast majority of patients. As we know, we had this evolvement of the device with the multi-layer braided Rotarex S since I think 2011 in Europe. And then we decided to have a look specifically with our chronic native artery patients treated with only with Rotarex S. And this was in total 658 procedures. And because of this concept that we talked about just now, we didn't take care if we're treating acute or chronic or pseudoacute patients. No big deal about demographies here. We only had what we normally have: hypertensive, dyslipidemic, diabetic patients. No big deal, okay, about what we had. But what I'd like to call attention is that more than 80% of patients that were studied in this cohort of patients were chronic and subacute patients, and mostly chronic patients, as you can see. 60% of those, we are talking about critical limb ischemia. So really severe scenario. We are not talking about short lesions. We are talking about real-world lesions. And as Ken just showed, we prefer to use, whenever possible, the 6 French for those chronic, because we think they work better in terms of not only winning the lesion, but also fragmenting and taking out material. So as we look to calcification, we're not talking about highly calcified lesions, but we're talking about mainly de novo lesions. Very high success rate again. So more than half of the patients we were able to treat only with atherothrombectomy plus PTA. And if we take the single use of Rotarex and the patients that were treated with PTA plus Rotarex, we have more than 75% of the patients. We did have 1/4 of the patients which needed some stent, yes, but I would like to highlight that this stent was, in the vast majority of cases, spot stenting. And we know that spot stenting is a lot better than long stenting in terms of patency. So again, perforation and complications very low, none related to the device. In some cases, yes, dissection in the beginning of the experience. No death related to the device. Very interesting TLR, both at 1 month, but also sustainable, very good TLR after 12 months, and a very good sustainable clinical result, improvement in the root of fall class. So here, I don't think there is any doubt that this patient is a chronic patient. So a lot of severe below the knee disease, a severe knee region disease with a lot of collaterals, but then suddenly we managed to cross the lesion and come back to the P2 segment.
Sergio.
And then we passed the Rotarex here only 1 time, and we were able to unmask a P1, P2 intercondylar culprit lesion that we then decided to pre-treat with POBA and then a Lutonix balloon with a very, very interesting result. as we can see here. Just coming back for us to finish here to that image, we first saw that image and I said, okay, sometimes it's not so easy. This appears to be an acute because of this material here in the upper part, but it's a chronic patient. He started feeling symptoms 4 months before his admission. And as we look to this patient here that seemed to be a chronic patient, such a long occlusion with collaterals, actually, even though it appeared chronic, in the real scenario, this was an acute patient that had only 5 days of history and was managed surgically. So it's really not so easy to identify sometimes whether a patient is an acute or chronic patient. But it doesn't matter, because our experience with acute and subacute patients told us that we can decrease a lot the duration of the procedure, also the dose of thrombolysis. We also avoid using it. We can also be effective in situations where thrombolysis would not be effective. It's our first choice in this scenario, either for embolic, thrombotic material, doesn't matter, and should be seen as an adjunctive rather than isolated option. We do use a lot this device together with DB balloons. We are also working on a publication for that. And also in the chronic scenario, very good success rate with the Rotarex S in the 3 scenarios, the vast majority of them, subacute and chronic, very low TLR rate, and also avoid a lot of metal being left behind. So as we think about mechanical atherothrombectomy in arterial occlusions, why shall we think of Rotarex as an atherothrombectomy device? Because it's fast, because it offers us a single session use, because it's a friendly use device, it's a very safe device, because it's effective. We shall not expect hemolysis as we do expect in many of the devices available on the market. Also, we can avoid thrombolysis, and we can, with this, unmask culprit lesions and then leave less metal behind. So we think that the removal of this soft core fragmentable material, no matter whether it's acute, subacute, or chronic, is fast and effective with the Rotarex catheter S. And we really think that the combination of this with drug-eluting technology is very promising and deserves future investigation. So I hope this was adequate for this initial discussion. I apologize for so many numbers sometimes, but I hope we could at least present our initial thoughts about this scenario. Thank you very much, guys.
Oops.
Sergio.
Oops. Okay, guys, we are here. Ken, do you want to announce me or shall I go?
Ladies and gentlemen, the one, the only, Sergio Riveloso.
Thank you so much, Ken. Okay, guys, now I ask you to stand up a little bit from your chairs and move together with me inside the cath lab. Actually, we will change a little bit the topic. We will talk about support, how we should support our native vessel case, and what tools actually do we have available in order to do that. So first of all, remember, you have the summary chart, which is available for you. If you don't have it, just ask your area sales manager or ask us at webinar@straubmedical.com. We can share this contact. You have all more or less the tips and tricks which are important during your procedure in this summary chart. But today we will focus in native vessel, as you already know. So we know that we are treating native vessel. We can face different kind of material in the same occlusion. We can face acute material. We can face chronic material. And in these two scenarios, normally we have different things we should pay attention to. When we are facing an acute phase of the disease, distal embolization actually is the worst concern I normally have when I support these cases. Coagulation into the catheter, we know, is a major issue when using the Rotarex. We know we have a rotating helix, which is rotating 1,000 times per second. So very fast rotation inside the catheter, which creates heat, and heat may cause coagulation into the catheter. And then we have many problems which have in this the origin. We can experience friction in the guide wire, we can experience breakage of the guide wire, or only partial aspiration from the catheter, or even the breakage of the helix. So really very important part is to avoid the coagulation into the catheter. And we also want to avoid vessel damage. Now, how can we avoid this situation to happen? We know that to avoid distal embolization, first of all, we have to select the correct size of the catheter. We know that between the 6 French Rotarex and the 8 French Rotarex, we have almost the double of the aspiration power. So very important to use another good adequate catheter size to avoid leaving too much material inside the vessel and maybe have then distal embolization. Slow movement is mandatory. We have to take our time in the procedure. Slow movement to allow transportation of material inside the catheter to avoid the catheter getting stuck. Continuous aspirations. Once we start with the motor, we should keep the motor running as much as we can. Leaving maybe, if we are treating a long occlusion, a distal cap, last 2-3 centimeters, not treat it as distal cap. This will work as a distal filter to give us protection from distal embolization. And then, when we are sure that we clean all the proximal part of the occlusion, only then we can move to treat very carefully the last centimeters. And what about, I think, the most important problem that may occur in the cath lab with our devices? What about avoiding coagulation into the catheter? For sure, we always try to remember you that heparinization is very, very important. We are not creating hemolysis inside the patient, but we are creating hemolysis inside the catheter. So hemolyzed blood will coagulate faster. That's why we need to pay more attention to heparinization compared to a standard procedure. And then now we start with some videos explaining to you the newest protocols when we are using our catheter. So first of all, attention to the guide wire. We know that if frictions start to occur in the catheter, the guide wire may start to rotate fast, to move. Normally it will come back very fast. So how can we notice this as fast as we can? Now we would suggest you to mount the torque onto the guide wire here, a few centimeters far from the wire adapter, the metal pin we have in the back part of the catheter, so that if the guide wire moves, we will be available to easily see it. Remember, the guide wire should not move together with the catheter, should stay fixed and secured by the second operator. Very important part. Also a gas in this part of the table may help to check. And actually, this is my favorite second operator, is Lorenzo, we know, and is always paying so much attention to the flow here in the collecting bag. Bravo, Lorenzo. And so, pay attention to the guide wire. Many times people are telling me, I'm working with doctors with a first operator. It's really difficult to train them because he is a top guy. Well, Then train in the perfect way the second operator. Normally we have more access to second operator, and you know, their ability, their skill, it's really, really important during our procedure. Other protocol, I like it so much. Start in 1, 2, 3. Simple and fast. What is start in 1, 2, 3? You know, normally we suggest you to place the catheter 1 or 2 catheter length, centimeters, but for sure catheter length give much more the idea of the distance in the open proximal vessel with the motor running but not moving the catheter. Then check the flow. Second operator will squeeze the collecting bag and see that we have flow inside the catheter. Only when we are sure that the catheter is aspirating in the correct way, then we can start the movements. Okay, so as you see here in the video of the perfect second operator, we start the catheter without touching it. Then we check the flow, and then we start movement. 1, 2, 3. Motor, flow, movement. Okay, and we have to repeat it every time the catheter, the motor is stopped. Go back in the open proximal vessel, then start the motor, check the flow, and move the catheter. Slow movement, again, to avoid to have too much material inside the catheter. We need to give time for the transportation, and then never force the catheter into an occlusion. We need to give time to the catheter to well open the lesion instead of, you know, pushing and forcing the catheter, creating only a channel. We will go back to this in the next part, vessel damage. Never, never, if you have a doubt of being subintimal with the guide wire, and make sure that the vessel is not collapsing onto the catheter head. So normally we try to explain this to you using these videos. We see here a perfect run-in of the blood to the catheter head. We show you normally these videos. This video where you have a doctor working inside a stent. If you have flow, the stent will not collapse. But what if we have a proximal lesion which preclude a good and adequate run-in into the lesion? We know that Rotarex wants to make this aspiration. The 6 French Rotarex is aspirating 45 ml per minute, and the catheter needs that amount of fluid to transportate out the material. So if we have an unsolved stenosis here, what will happen is that the catheter will collapse into the catheter head, which is not good. We have to first solve the proximal stenosis and then move forward. We need to be sure that every time we have plenty of fluid at the catheter head. And do you think it's different when we are treating a native vessel? No, it's not. If we don't have flow at the tip of the catheter, the vessel may collapse. In this case, we are not protected by a stent, so we may have a dissection in the artery. So let's have a look. Here, for example, we have an hard, not fragmentable lesion in this area. Let's have a look of what normally happens in that situation. We have a good flow until the occlusion. But then, you know, in this case, we have a not fragmentable lesion, which will reduce our lumen by 50%. And we know that by the law of Hagen-Poiseuille, a reduction of diameter of 50% means a reduction of flow of 94%. So inside the lesion, the flow will be very, very, very reduced. And what if we place on top of it our Rotarex, which is 2 millimeters of diameter? Well, probably the flow will be almost zero at the catheter head. So what happens here? It happens that the vessel wall may collapse. That's why we need to be sure every time that we are not just pushing the catheter inside the lesion, but that we are, opening in an adequate way our vessel. That's why slow movement and always pay attention to the proximal part of the lesion, which normally is the strongest, to clean it in a good way before we proceed more distally. We have to solve the proximal cap. We have to work very slowly. And, every time we say okay, just a second. Every time we say that you should pay attention to the audio, we are not deciding the speed of the movement. The lesion is decided the speed of the movement. Every time you hear a sound changes, you have to come back and proceed slowly. Tell me how many times you hear during the video the sound changing.
It's the proximal cap. So we want to be sure we have it removed.
You see how careful was the doctor? Every time the sound changes, come back and proceed even more slowly. We discussed about fem-pop area, mainly. Iliac are completely, in my opinion, a different story. And this story, well, Lorenzo will take you through.
Thank you, Sergio. Thank you very much. So now
you're welcome.
You should see my presentation.
Just a minute, Lorenzo. Yeah? I have to do the big introduction for you.
Of course.
So from Milan in Italy, we have the very great knowledge to be shared with us of Lorenzo De Nova.
Thank you, Ken. Okay, so let's focus a little bit on the iliac, native vessel iliac occlusions. Maybe we already know that it is something different from other segments. And, let's say that we have a doctor calling us for an acute iliac artery occlusion. And we saw also, and we listened to Dr. Freita's presentation, to the recording from yesterday's presentation. It is difficult to know and to understand if an occlusion is acute, subacute, or chronic. Usually we have a more complex situation. Maybe we can have an acute on chronic situation. So what do we know about iliacs? This story, so the fact that it's not just acute material, we have a chronic disease, is even more keen to happen. It's more often we have an acute on chronic situation. Maybe the acute is the symptoms of the patient. So the patient starts developing pain in the leg, but the disease is a more chronic disease. Plus, in the iliac arteries, we have very often also calcification, which we had a very nice discussion at the end of the meeting yesterday with Dr. Freitas. Calcification there are really a different kind of calcification from the one that you can find in the SFA or the popliteal artery. Here we have very strong calcification. It's really easy to go subintimal. It's really hard to stay intraluminal. The other aspect that we need to consider is that when treating an iliac artery, usually we need a stent. And stenting in an iliac artery is different than stenting in an SFA or popliteal artery. We know that avoiding stents in SFA or popliteal is a big advantage. We can focus on just the culprit lesion. We can have shorter stents so that we have a better patency on long term. We know that more or less SFA, a popliteal segment, 30 to 35% of stents are going to occlude again in 1 year. And longer the stent, worse is this situation. In an iliac artery, putting a stent is not a big deal, considering the patency at 1 year, because we have studies that are showing that the patency is really high, almost 100%, 96%. So stenting is not a big deal. Of course, what I was saying, here we need to pay extra attention to the passage of the guide wire. High risk of dissection here, and dissection in this artery, iliac artery, big vessel, a lot of blood, could be very dangerous for the patient. When we are talking about iliac occlusions, there is no try, do or do not. You need to be sure of what you are doing. There is no, let's say, what is going to happen if we go with Rotarex, okay? So let's go to some cases. Here we have an occlusion of an iliac artery, clearly seen. So let's treat it if we are sure that there is an acute component. We are sure that we can cross this lesion in an endoluminal way. How to do it? How to know if we have this fragmentable core lesion, this acute component? Let's do the soft guide wire test, as we called it. So we take a soft guide wire, for example, a starter. We can discuss about it. There are some guide wires, for example, the Roadrunner from Cook, that are with a soft tip. So it's really easy that this tip is going to loop if it's facing a strong occlusion, a stronger material. So it gives you a feedback of what you are crossing. So let's pay attention to the loop, and if there is resistance in crossing the occlusion. Okay, these are a couple of signs really important. Let's see this video together. So here, as you can see, we have a support catheter here, guide wire going through. This was a starter guide wire. Look, guys, how the guide wire is crossing the occlusion without any resistance. It's going up a lot of centimeters far from the support catheter without looping. The doctor feeling here is that the guide wire is going through very easily. Again, it's advancing. Then it's giving some support with the support catheter, but it's not that it's pushing through the occlusion with the support catheter. The guide wire is going through very easily. Here we have the point of the bifurcation, and then it's gaining the aorta lumen in the last stage. Really easy. How much time? 30 seconds, and we are through the occlusion. No loop, no resistance. So if you look at this soft guide wire test, again, this is the two main aspects to pay attention when we are in the cath lab. And then what they decided to do, they decided to treat this patient with a Rotarex 8 French with a retrograde approach. 8 French, why not a 10 French? We are in an iliac artery. We know that they are big vessels. This is true, but we are in a native vessel. So 8 French is enough to treat this kind of occlusion. With a retrograde approach, which is telling us we need an infusion, otherwise we don't have enough flow at the tip of the catheter, and we can have some problems, as Sergio showed before in his presentation. So here, 8 French Rotarex, and I want to point out the speed of the catheter. 1 headline at the second. So the length of the head of the catheter is 1 centimeter. They need to advance this length and then to go back, okay? And see how the doctor is working slowly, staying a lot in the same point with this back and forth movement to allow the catheter with the vortex to fragment and take out all the material, the occlusive material, the fragmentable core material. There is no speed. We don't cause hemolysis. So there is no reason to go fast. No problem. Take your time, make them go slowly. Remember, the length of the head, 1 centimeter per second, which is more or less 1 centimeter. And so they have a visual reference on how fast they can go. And Ken is laughing because I'm used to say 1 centimeter per second, but now I need to change to 1 headline per second, and it's confusing me a little bit. But remember that the head is 1 centimeter long, so it's okay. But he's right. Telling them 1 centimeter per second is all relative because, okay, 1 centimeter, it's fixed, but it can be a little bit different. The length of the head, you cannot get away with that. It's the length of the head, okay? And look at the result here. 1 passage, we were able to take out all the material from the iliac artery and to see here the culprit lesion. It's clearly there. It's the reason of the occlusion. And now we can decide what to do. So are we going to do a second passage? Are we going to do a PTA? Are we going to stent? Let's see what was the strategy. But first, working slowly, it was possible to take out all of this material, occlusive material, fragmentable core material. At the end of the day, they decided to stent. It was a kissing stent. I go fast here to solve the tight stenosis that we had at the bifurcation, and the result was quite good. The speed of the flow is really nice. Stenosis almost solved. As you can see, even the stent was not able to solve it 100%, but the speed of the flow was quite good, so the result was very nice. Let's see another case here, for example. Again, is it an acute occlusion? Do we have a fragmentable core? Can we cross it endoluminal? Let's do the soft guide wire test. Again, we take a soft guide wire and we go through. And look at here, especially in the first part of this video, you can see the guide wire is struggling, okay? It's bending. And also the support catheter here, it's bending together with the guide wire. It means we have some strong material here. Then eventually the doctor was able to cross it, but as you can see here, the support catheter is bent. Here we have a big zoom here, so it means that here really we cannot advance many centimeters before with the guide wire. The guide wire needs the support of the catheter because otherwise you have a loop. Yeah, in this situation, with this test, we can discuss about it. What to do? Are we sure that we are endoluminal? Are we afraid to be subintimal in some centimeters of the occlusion? So we can discuss about it. We can talk with the doctor to understand which is the best strategy. Maybe we can run a 6 French Rotarex, which is smaller. So we know that we are less aggressive on the vessel. On the other hand, you need to consider that the aspiration power of a 6 French is more or less half of what we have with the 8 French. So we're talking about 45 ml per minute instead of 75 ml per minute. We can discuss about it. If we use a 6 French, maybe we are not able to take out all the material, so we have some material left. We need to deal with it. And yesterday, Professor Freitas was telling us that if he has to choose with this kind of Rotarex, so the 6 French, then if he need to stent, he would choose a cover stent, so he avoid to have deembolization because of the material squeezing through the struts of the stent. Okay. At the end of the day, here they decided to stent again to solve this situation. We have the inflation of the balloon, and here you can see the final result. Again, what you can see here is that you have a good speed, so the result was quite good with a stent with no passage of Rotarex. And this is important to evaluate properly the passage of the guide wire, because we want to avoid this kind of situation. This is a small dissection. You can see the contrast going out from the vessel. We want to avoid this. So let's pay attention. When we are in the cath lab, we have a lot to do. We have a lot of things to take care of. But remember, when they're crossing the occlusion, always pay attention to the behavior of the guide wire. Ask questions of the doctor which guide wire is using. Sometimes they try to use the CTO guide wire, which are really heavy guide wire, so they tend not to loop and to go through easily going subintimal. So choose also you can suggest the correct guide wire. So let's start with a soft one. Let's see what we are facing. Let's see if we have loops, and then we can decide what to do. I'm done.
Bravo, bravo.
Well, thank you, guys.
Yeah, really nice, really nice. Good.
Thanks.
So that was
so
a really nice.
Anything to add?
No, not at all. I'm just reading the chat here. Arian commenting that iliacs are his least favorite case, because when we get a complication in the iliac, it can be very serious. And I remember, Arian, being with you. The only case in my 15 years with STRAUB I had to walk out of was the hybrid case that we did with a patient in Netherlands who, while the radiologist was trying to open up a chronic iliac occlusion and actually caused a small perforation, the vascular surgeon was amputating 2 of the patient's toes and all the maggots spilled out all over the table. Yuck. Was not the best. Was not the best. However, no, they yeah. So when we have that complication in the iliac, it can be extremely serious. So we're going to be We have to be in the iliac artery, super sure we are intraluminal with the guide wire. It is very, very, very important. We have to know what we're going into. If we are at all unsure, we're going to think twice about doing the case, because it can be very serious. Would you agree, Sergio? Lorenzo?
I totally agree. I would be, I'm sorry for saying that, but I would be even more conservative, Ken. Because, for example, in the second case Lorenzo showed, I was probably sure that we were still endoluminal. The problem, in my opinion, is that sometimes you had those plaques in the iliacs, which are really stones. So, in my opinion, even though we are, intraluminal with the guide wire, we really need to think about the benefit of using Rotarex in such a scenario, because you still have some possibility of torquing a really hard plaque inside the iliac. And we know that, despite they are bigger than SFAs and popliteal arteries, I think they are more fragile. So normally, my decision-making process is really, do I have a lot of thrombotic component in the iliac, or is more something, older? If my answer is something older, probably in that lesion I have to place a stent anyway. So it's worth it, the risk of doing a Rotarex in that iliac, or is not worth it? And if the answer is maybe, I will avoid the case.
I was being a little bit less conservative because I was talking to you, Sergio, and I know that you're quite good at doing the cases. Just want to point this out, everyone, that when we're talking about the iliac arteries, this is what we see on the angio. This kind of straight line here. I always like to just remind people that the iliac arteries go quite deep in, and there's quite a lot of angles here, remember. So what we are seeing is on the angio, we're seeing a straight passage, but in fact, it's not at all. And most of the patients that we're treating, they have a little bit of tortuosity in here as well. So when we're talking about the common iliac artery here, to get there is quite difficult. If we have an occlusion, which is coming into this part, really chronic, and they're almost always calcified. You don't very often see iliac artery occlusions which don't have calcific component. Everything's at strange angles. We're not working straight down like we are in the other vessels, like the, just a minute, I got to do the zoom here. Like the SFA here is you see how straight that is all the way down, right? We're really straight. So just remember that the iliacs are going really deep in and then up. Be careful when working in the iliac. Make sure you got a bailout for sure.
Yeah. Okay, and don't be afraid to be conservative. This is also a message.
Yeah. I think that sometimes it's better to lose, a case, where, for the patient, the alternative treatment, as you said before, is a stenting, which has in that area very good long-term patency. It's not a popliteal artery or an SFA where if you put a stent, that sooner or later the patient will come back with an occlusion. In the iliac it's not like that. So I think we only need to treat the segment if we really think that an angioplasty there or a stenting there will create a distal embolization, will be limb-threatening for the patient.
It's a different game, though, altogether, everyone, isn't it, when we're talking about in-stent iliac occlusion and EVAR graft occlusion. This is a different game. Those are perfectly safe to treat, no problem at all. When we're working in that native artery, you have to be super careful.
Yeah. As you can imagine, folks, we already started the Q&A session, so feel free to ask your question to the panel.
I have a question.
Go ahead, Ken.
Does anybody have any questions?
Go on.
This is your question? Okay.
That's my question.
So
Can
I
you
have
cut
some,
this from the recording?
Yeah, we will. I have a questions about the guide wires. Guys, would you recommend some specific guide wire? And I'm talking in general now, not only iliac, but also we understood from Lorenzo that the iliac probably is better to be an approach with a really soft guide wire, probably a starter even. But when we are talking about SFA and popliteal area, would you recommend or would you avoid using some specific type of guide wires?
Ken, do you want to? I can.
I mean, I think I would avoid using CTO wires
exactly
in the iliac, to be honest.
But also in an SFA, when it's chronically diseased, maybe again there the risks are less big than iliac, but still, if you use a CTO guide wire, the risk of going subintimal is really, the chance to go subintimal is really high with this guide wire. So, and
you're going deep subintimal. It's not just passing just out of the lumen and back in again.
Exactly.
You're going in a straight line. Again, we go back to drilling the hole in the wall, right? When you put in the screw into your hole, if you're a little bit offline to begin with, you're really offline at the end every time. This is me. This is my life.
Yeah.
Shall we launch the poll?
Yeah.
Do you like, guys, if I do that? Okay, so let's ask our audience, what is your favorite take-home message of the day about flow, about guide wire passage, about, you can treat with Rotarex is the only device which allow you treating chronic and acute material with the same device, or do the math, which is a concept we are trying to launch in the last months, doing mechanical atherectomy plus thrombectomy with our device. So we give a little bit more time to our audience to answer this. Another question, guys. I mean, when I'm really scared, when I go in the cath lab, is when I still see occlusions in the proximal parts of tibial vessels. What would you recommend in this kind of scenario? We know that sometimes we have occluded pop and occluded, the first, I would say, 3-4 centimeters of tibial vessel. What would you recommend in that scenario?
I would recommend to stay with the finger on the button of the drive system, ready to turn it off when they just cross, the end of the popliteal, the distal popliteal, so that it's not working anymore. No, joking. Of course, I'm joking. Sergio, your explanation before of the flow in the vessel when you have some strong material, I think it was really nice. And considering that even if we have a 6 French, the tibial vessel is 3 millimeter something. So the 6 French is almost 3 millimeters. So I mean, it's almost closing all the gap between the vessel and the catheter itself. So for sure we don't have flow. So the risk there to work without flow is really, really high. And we know that we need to avoid it in every scenario. There, even most likely. So it's better to stop at the distal popliteal level, and then to suggest a doctor to solve, to gain, the one vessel or another vessel in the tibial with another technique. So angioplasty for sure. It's
yeah, or trying maybe the last centimeters with manual aspiration or something like that. Totally agree. Ken, would you add something?
I don't think I need to add anything there. I think that's good. I think we covered it.
Great. What is your favorite take-home message, guys? Last round and then we close.
For us, same as yesterday, my friend, flow. flow. Let's work with the flow.
Yeah.
Yeah, of course, I think that this one won also yesterday from our audience. So for sure, flow is really important. Is a very, very important point. Again, I would like to stress out a little bit the guide wire passage is always a an important point. We know that subintimal is a contraindication for Rotarex and Aspirex, so it's the first step to have a successful procedure.
Okay, for me, actually, yesterday, I changed my mind. Yesterday, I said, the Hagen-Poiseuille law, because you always have to take out as much material as you can. Otherwise, you will have a very important flow reduction in your blood vessel. Today, I don't know. I would
it's
like.
It's a different day. So.
Yeah. No, actually, today I would go for one of the other answers, which is we actually have the only device who can really treat different kind of materials, acute, subacute, and chronic. No other competitors can at all claim this. So this is, I think, an advantage, because, when you see an occlusion in the screen, you never know if it's only acute, only chronic, in which percentage one or the other. So I would go for this one.
Good.
Nice.
Really nice. Well done, guys. Well done, everyone. Thank you very much.
Thank you.
Thank you,
and
guys.
Thank you to our wonderful
audience.
audience. Yeah, as always, thank you for joining us this morning, and have a great day. Thank you for your input. Take care, everyone.
Ciao, ciao.
Thank you,
Ciao.
guys. Thank you.